All right. Good morning, or good afternoon, one more minute. I'm gonna go ahead and call us to order because we're early and all here, which is awesome. So it's great to see everybody. We do not have anyone for the privilege of floor, correct? That I'm aware of? Okay, for Liz, nobody that you know. Let's go ahead and take a look at the approving our minutes from January, since we didn't have a meeting last month. Motion from someone to approve as written. I have a first from Ravinder and a second from Sue. Any discussion, edits, changes on these? Okay, all in favor? Anyone opposed and abstentions? Yes. I'll go ahead. Is Jeremy here?
Trying to join.
Oh, okay.
You wanna-
Yeah, there's Jeremy.
Oh, there it is. Oh, hey, Jeremy.
Good afternoon.
Good afternoon. You hopped on exactly at your time in the agenda, so we're ready for the financial summary.
Oh, good. Good. So are you all looking at, sorry, this is my first time doing this. Are you guys looking at paper documents then, or do you guys share a presentation here? Okay.
We have the paper document that was provided in the board packet.
Okay.
Yeah. You need us to introduce ourselves, Jeremy, since it's your first time?
That would be
that help?
excellent. Yes.
Okay. So, thanks. Shauna, can I start with you?
Sure. Shauna Black, I'm on the legislature. Jeremy.
Hello.
Merkel, retired from Cornell University microbiology.
Ed Coppell, physician at Cornell University.
Melissa Dundal, I'm a pediatrician. I work in school health.
Christina Moylan, from the School of Health Sciences and Human Performance at Ithaca College.
Joanna Nima, I'm the chief medical officer for Cava Health.
Ravinder Kingra, Board of Health member.
Samira Touchton, Board of Health member, nurse practitioner in the community.
That's all the board, Jeremy. Welcome.
Thank you. All right. So what I did was I looked at what you guys have been presented with in the past early in the year, because you guys would have already seen the budget last year, and we are not quite closing out our books from last year, so I can show you all of the actuals of what happened last year yet. And so really what you're seeing is an early year, really early year expenses and such year to date, knowing that not much happens actually in the first couple of months. Most of the revenue has not come in yet. We haven't spent a lot of money yet. So I don't have a ton of extra to add to this. If this is sort of what you're used to seeing, in the future, you may see things a little bit differently as I hear what you all say. And I want to make sure that you get, the best information that you can, without getting into such detail that it's meaningless to you. So certainly any large changes or things, I would highlight those. But this early in the year, I don't have any big systematic or programmatic changes to talk about. Did anybody have any questions about what you have in front of you?
No. It looks pretty typical for this time of year, so.
Okay.
Any questions from any board members at this point? Okay. Thanks, Jeremy.
All right. Thank you very much. Nice to meet all of you.
Nice. So, Dr. Claypack is not here today. So we will have to have his report stand on its own. If anyone has comments on the report, but not here to discuss. So we'll go to Frank.
Don't really have a lot to add to this report, but just some goings-ons that you should be aware of. I don't know if you've heard, but the Alcohol and Drug Council of Tompkins County has suspended operations. And so we've been spending, I've been spending a lot of time over the last few weeks helping them transition to the Oasis. The primary focus in the early weeks was transitioning clients to other care. That process is now essentially completed. And we are focused on next steps of closing down them as an organization and making decisions about how to move forward. How to move forward with the programming that they were providing. Just so you all know, there are three main areas: prevention services, for which they received funding but were not licensed. At outpatient clinic, for which they received funding and were licensed, as well as a detox facility on Trip Hammer Road, for which they received funding and were licensed. We are likely going to be RFPing for all three of those services to find alternative providers that would be interested in doing it. Both the county and Oasis are committed to getting the detox facility open. And so this, while it is unfortunate, is not the end of that. In fact, I'm hopeful that through this RFP process, we may be able to look at a more holistic approach to using that facility to include both mental health and substance use, rather than just being substance use as it was previously being developed. So that's eaten up a lot of my time over the last month or so, trying to navigate through that, but we will continue to support that as it unfolds. There are two additional RFPs that are out there in the community. One closed, actually, both of them have now closed. One was for opioid settlement funds that came through the local government unit, which is overseen by the Community Services Board. And that RFP was to provide rapid housing and wraparound services for individuals that interact with the crisis system. And so the legislature, the process is going through the legislature to accept Catholic Charities of Tompkins and Tioga as the vendor for that. So we're hopeful, I think by the end of the month or early next month, that'll be finished with the legislative process and we'll be able to start contracting with them. So that's exciting. The second RFP was for the outreach worker program, which is a combination of what was formerly the Downtown Commons Area Outreach Worker Program and an expanded countywide one, which Harmony secured last year, secured state funding for to expand to the rest of the county. So that funding was 1 year. Thankfully, the legislature has supported that through an OTR moving forward, and we were able to bring the two programs together, partnering with the city of Ithaca and the Downtown Ithaca Alliance to have a countywide approach. So that RFP has now closed, and we're in the process of reviewing applications now. But hopeful that both of those things will be operational within a few months' time, which will be a big addition to the service continue. Yes,
When you look to expand what services you're doing, can you see if you can include teens and young teens in that, especially the substance use issues, because there's not that many services for them. And now without Alcohol and Drug Council, there's
Sure. So the prevention programs generally are targeted at
many treatment programs.
Yeah, so the treatment part of it should be providing for all ages that are
Down to 11 and 12 years old.
I believe so. But we'll double check and make sure that.
Thank you.
Sean?
I had a question in regards to Alcohol and Drug Council. So the county is going to do an RFP for the services. Who owns the business or owns the building?
So the building should revert to the state, to Oasis. So as part of the funding that was secured for that, a lien was placed on the building associated with it. We're trying to get clarity from the state about that because we can't really RFP until we know the full assets that will be available. But we are like 98% confident that the state will have the building and we'll be able to include it in the RFP.
So does that mean that the state's gonna have oversight on who receives the award for the RFP?
Generally speaking, they do anyway. So how these RFP processes work, the Community Services Board technically has jurisdiction over them. OASIS has oversight responsibility for that, so they will review both the RFP before it's released and the selected vendor once we get to that process.
I just, different topic, wondered if there was anything in the state budget that I think got passed recently. Didn't it get passed recently? No, they're still talking about it? Okay.
There's some school hubbub.
Just wondered if there was anything that impacted public health.
There's a few things. There was a couple of programs that rabies funding was cut. And there was a couple of others. Those we think, they're your typical, we're gonna cut things that there's no way the legislature's not gonna refund. Activities, again, that's me being cynical in a very public meeting. So I think those will likely they're relatively small numbers. They're not making a huge impact on the budget. But the commissioner's response when the question is, well, we had to make cuts somewhere. So you cut the things that they're gonna fund back. The biggest probably impact is early intervention. So there is a proposal to increase 4% everything or 5% everything, 5% everything. And then a 4%, an additional 4% in areas of high need. They didn't identify where those areas of high need are, so we don't know if we would fall into that. I can't imagine we wouldn't. But that's still only 9%, and we were looking for 11% last year, which was barely scratching the surface. So there's been a lot of conversation and advocacy on that front, trying to get some understanding that there needs to be rate increases. We have been looking, Jessica and her team have been looking at the positions that the legislature gave us. Unfortunately, we've not had a lot of applicants. And so we are back at the drawing board, trying to put an alternative proposal together to take back to the legislature as a different option to try to help deal with our wait list issue that we have for the children. So that'll be coming in the next couple of weeks, month to the legislature for consideration. So those are the biggies on that front.
And schools, if they go, if the budget goes through, some of the schools will get really big cuts. So like millions of dollars, 1.5 million for first districts. I think there's a lot of pushback, so hopefully that will happen.
For what, so
K through 12.
but for what kind of funding? Just general?
General
education?
funding, she wants to get rid of a safe harbor thing, which I don't really totally understand, but every school district would have a cut and they wouldn't. They're not supposed to decrease from the prior year, but this would allow them to decrease the funding that they got. But I think there's so much pushback, so I'm hoping it doesn't go through, but I think that's part of the holdup. But that affects health. Schools affect health, that's all.
Right.
Yeah.
Just one other thing, because Dr. Claypack normally would have brought this up, but Nassau County has identified a case of measles.
I was about to mention
Oh, all right, I'll leave that some Rachel. I don't know.
Can you talk a little bit about this new opioids page that was?
Oh, sure. Yeah, so we just launched more data on our opioid resources page on the website. It is the medical examiner data. There's some demographic information for those that unfortunately died from an unintentional overdose. We aggregated the last 5 years of data because it's 100 people with the 5 years aggregated. So really doing it year by year, the numbers were too small. So there's data about age, race and ethnicity, occupation, education level, marital status, veteran status, the months of the year, the numbers that we saw, particular months of the year. And I think that's most of what's out there. Two things that I think stood out. One was Black African American, I think it's like 18 out of the 100. And so that's about 18%. Our population's about 8. So still, we're seeing a population that's unfortunately being disadvantaged around another health outcome. As well as 22 of them reported food service as part of their occupation at some point. So that kind of jumped out as a place that we might have an opportunity to do some education or outreach around that workforce population as well. So that data is out there. It is the first step, and what we're hoping is a larger data project. We control that data because it's from the medical examiner and they report to us. What we really like to see is data around overdoses that don't result in death. And so we are working with CAG Health Partners to see what kind of data we can get, particularly related to the emergency room. So our goal was to kind of get our data out there, show them what it is we were trying to achieve, and then work with them to try to get that information as well. There had been a lot of conversation about us taking in PHI, protected health information, de-aggregating, de-identifying, doing all of that. We just don't have the resource or capacity to be able to do that. So our path now is to go to our partners and say, what we would like you to give us is already de-aggregated, de-identified data that you would be okay sharing with the public, and let us put it with our data so it kind of paints the whole picture. So we're starting with CHP. We'll also talk to other partners in the community as makes sense, but we really want to be able to paint that picture, the same demographic picture around overdoses that did not result in death as well. That's the next step. John?
Yeah, so I mean, I'm a little concerned about, I'm going to push back a little bit in regards to the no resources, because I feel like, for one, this is the first time that we've ever heard that we don't have the resources to create data. And, you know, as far as I'm concerned, we sat in this room about 6 months ago, maybe even 8 months ago. And one of the grievances that I had was that the data is not being presented. You know, we should know how many people are dying of overdose in our community. And while I understand, I think it's important that we all realize that we're not talking about one person in Newfield. It's a male, it's African, like, we're not asking for you to pinpoint who is actually dying. But I think it's important for us to talk about those numbers, because in order for us to actually do something about it as a board and as a community, we should know those numbers. And I don't think it should be a secret. And I feel like, you know, at this point, when we're talking about PHI and sharing information, like, this group of professionals around this table need to be part of coming up with new ideas that are going to save lives, because we've seen such an increase in deaths in our community. I mean, it's absolutely heartbreaking. And I'll be very honest in saying that I feel like this board has not done anything to help with that. And, you know, we talk about a lack of resources and not having the funding. If the funding was asked for, if you said, Shauna, give me $150,000, we'll hire someone to look at the data and present data and figure out ideas and ways to reduce overdose, I'd go in front of the legislature tomorrow and we would have someone hired. So, I mean, I want to kind of take us all to task, because, you know, this is something that I have constituents call me at least once a week. They're losing their sons, their daughters, their brothers and sisters. People are dying here. And I think that, you know, like I said, this is the board to make things happen. And
My question was, how many of the people who have non-fatal overdoses are actually making it to the hospital? Do we know that, or how do we collect all that information?
That's the question, right? So we don't control that data. It's through, we already report the Department of Emergency Response calls on our website. We've been doing that for, I want to say, about a year now. But as far as, I will tell you, we had an overdose in front of the Green Street building last week, where staff had to administer Narcan to revive the individual, and the person refused transport. So I don't know the answer to that, and that's part of what we're going to try to figure out. We know a large number of them do go to the emergency room, so we want to make sure that we have we can find that information. And then I think that's kind of the conversation with other partners about how we can get additional data. That's one of the challenges. We don't control the data. If it's ours, it's a I think the simple answer is we have more overdose than we should, and we have more people dying from overdose than we should. And I don't think that's I don't think that's a secret or something that we haven't been saying. I think we want to provide as much data as we can that's useful for folks, and we will continue to do that. But we don't control it. So building those partnerships is going to be a big part of trying to answer that question.
So Frank, I thank you for that. CHP is truly the place to connect with because they would be able to share as much as they can in terms of ED visits, admissions. I don't know exactly how you would cross the information, right? Because you own the information about the path of the patient up to a point, and then how you connect with what happens after they get to the hospital. But I know you have worked with them for many years for the pandemic. That's the way to go.
Yep. Yeah, and they've been very helpful in your own conversation. So I think we're on the right path.
Are fentanyl test strips widely available and or used and or effective?
I don't know that I would say widely. I think they certainly are available, and certainly our community partners that are serving those with significant drug use like STAP and REACH and others have access to them and hand them out. We as a department have them and can hand them out when asked for them. There's been some conversations with other more non-traditional community partners. I know some of our substance use subcommittee members have talked with local bars, and there's been some positive movement there. So I wouldn't say widely. I would say that we have access to them, and anyone that wants them could have them. But as far as them being everywhere, I don't think we've kind of made it that far. Honestly, I'm not sure we've gone as far with Narcan as we probably should either, particularly after what I witnessed last week. There's things we're going to do in our building to make Narcan more readily available because of that situation.
Yeah, I was gonna ask if you give it out downtown, and also do you have an age limit on who you give it out to? Because when I went to the pharmacy, it's like $48 in the pharmacy and you have to be 18.
Yeah.
So.
Yeah, there is the age problem. I think one of the things that we're gonna look to do is to try to have it available just outside the building. So people could just grab it, similar to what staff has done in front of their building. They have a box out there. We obviously will have to look into the age thing before we do that and figure out what our liabilities and concerns around it are. But yeah, our hope is to have, we have it in the building, right? So we keep it behind the front desk, which is where we got it for this particular instance.
So like a teen walk in and ask for Narcan right now?
I
We can
don't,
talk about it later.
yeah, I don't know the specifics of whether we're aging people or if we're just handing them the box of Narcan. I don't know the answer to that. But I know it is certainly a challenge.
But are there state regulations regarding the age to?
Yeah.
There are.
And there's like, you can't give it out on school campuses. NCLS is super supportive and working with us to try to change school
Seems like a good
regulations.
place to give them.
But there's multiple governing bodies. There's NICID and DOH and only just everyone, so.
Yeah.
What's your sense of, so even if we had perfect data out there, what's your sense of how the community is using that data to do anything? Aside from look at it and comment on the fact that it's worse than we would like it to be.
The community, I don't think there's much happening around it. I think there are key community partners that are using their own data on what they see to make decisions about, what they do. STAT, for example, is part of the state pilot program to test drugs, which is where we got the information about the fentanyl and xylazine in the local supply. I think it's an awareness thing more than anything. I think painting the picture about who's being impacted is important for that very reason, right? It creates awareness that it's not just a particular population, it's everyone that's being impacted, and everyone should be aware of what to look out for and what resources are available. I think that's, the direction that we've been taking with the data and our communication around it. As far as action steps, I think we've brought different things forward to add programming based on what we know about the data from our department's perspective. But do I think there's wide community usage of what's out there? Probably not.
So I'm gonna just circle back around to Shauna's comment, because so again, the question for me is, even if we had more data out there, what purpose is it serving, right? So before we start funding people to get more data, how are we gonna use it if we have it? So that was why I just asked that question. But then the second piece for me is, calling the board to task, I think, on not doing enough. It is, again, so part of it is about data, but then it's like, well, what is it that we think that we should be doing that we're not doing? Right? Because otherwise you made a statement, but we're gonna leave here and not really know what that means in terms of next steps. So from the health department's perspective, if the role here is about raising visibility with data, like that's one strategy. But are we suggesting that there's other strategies that we think that should be pursued?
My vision is that there has to be an education piece, there has to be an alert factor. And it's just ongoing communication, which I don't think we have here from our health department. And, unfortunately, whenever there's an overdose, it feels like whole health is silent, and we're seeing the Ithaca Voice is reporting, and it's coming straight from IPD or the sheriff's department. And I feel like if we really want to control the narrative and put out true public health information, then it should be coming from the health department.
So Sean, and I can appreciate what you're saying, and I agree there's certainly more that we can do. In the first 2 months of this year, there was not a spike. It matched what happened a year ago. The numbers being reported in the newspaper were not accurate. And the information about what's going on from a law enforcement response, we don't have access to that information unless they provide it to us. So I can appreciate, wanting us to be the voice of that issue. And I agree, we need to be talking more about it. We were already working on communication that went out shortly after those newspaper articles, because we were looking at it and working on it. But we can't control what IPD says or when they say it or who they say it to. And we don't have a strong relationship with them right now to get that information. We're certainly working on it, and hopefully it will be better in the future. And hopefully having our care team operational give us access to more real-time information directly that we don't have right now. So I contacted the State Office of Drug User Health. They did not see a spike in their data based on what was happening here. It's unfortunate that 5 deaths occurred. There needs to be some, I guess I need some help understanding exactly what folks want to see or what they want us to be saying, and we'll do our best to try to do that. I don't have access to all of that data that from those different sources. And I would also suggest one of the questions was around bad batches of drugs. All of our drugs are bad batches. Everything has fentanyl in it, and 74% of what staff tested had xylazine in it. So there is some challenge about messaging about bad batches when it's all bad, because then there's complacency starts to occur, right? That, oh, they haven't said anything about a bad batch, so it's not in the forefront. So we are continually trying to evolve our messaging and align it with what the state says is best practice. Talking with our community partners, including staff and reach about what they suggest. This isn't a simple solution, and we are doing a lot of work in the background to try to stand up programming and opportunities to try to get ahead of this. If we're not meeting communication expectations, we'll certainly do more about that in whatever way makes sense. But it's not always as simple as something ends up in the local newspaper and it was before we said something about it. And that meant we did something wrong or we weren't being proactive about it. We're trying to build partnerships, so I'm a little bit uncomfortable even talking about what we do and don't know from particular partners. But it does impact our ability to be more proactive on some of these things. So yeah, I hear you and I don't disagree. I want us to be out there, you know, as a voice that people are hearing about this issue. I would put our track record of putting actual things into action ahead of most other folks in the community right now. And we can certainly talk about what those things are if that's of interest to the board. So you know, again, I hear you, we're working on it and we'll continue to try to meet your expectations.
I wonder if we should come up with next steps. I mean, we sort of talked about it because we can sort of talk generically about how we're trying to build relationships and foster relationships and rebuild relationships. But do we just need to come up with, these are the next steps that we want to have in place before our next meeting? Like, do we need to meet with the IPD? Like, do they have a representative who handles, you know, these sorts of things? Do we need to meet with people from Ithaca Times or Ithaca Journal? I just don't know. I mean, I'm relatively new to all this. And maybe it's a very simplistic way of looking at it, but you know, when I go to a meeting, I want to have an agenda, which we always have, and I want to have next steps. So we're not having the same exact conversation again. And so I don't know if that's something that we can do to sort of start to get things rolling even more, not to take away from anything that anyone's doing, because you're all doing far more than I am. But just an idea.
I mean, I guess the question, Frank, is that you had mentioned, you started out mentioning that we didn't have the resources and we're starting to work on our next year's budget. Like, would it make sense to talk about, I know that we used to have Ted Shealy who handled the non-smoking, I don't know what it's called, but smoking equals bad campaign. Would it make sense to hire someone with maybe an NPH that could handle overdose prevention or overdose communication? So that can be their one focus and we can know that one person is handling, you know, from the beginning to the end, everything from communication to the dashboard to working with IPD to going into the schools. Like, I mean, it's such a broad job description, but I think, you know, right now you have, you know, a handful of people that are interested in this and you're tasking each person with a little bit of it. And it just seems like it's not really coming together.
Yeah, I mean, we'll always gladly take additional people. We've been using our fellows, to your point about passing it out. We have two fellows that are working on this. One's working on the data, the other's working on the RFPs and trying to get the services operational. Yes, I mean, certainly that will be beneficial. I think we've talked about wanting to have an NPH/epidemiologist as part of our team and being able to use those skill sets to kind of help move some of this forward. So I will certainly take that as an opportunity as we move forward for 2025. I'm unsure of what our instruction around budget development is going to be as far as growth. But I will make sure that it's something that we include for at least consideration, whether it's, you know, supported by the county administrator's budget or not. So that way the legislature can think about it.
So back to Ravinder's point, though, this is a question for the board, not for Frank. So what are we looking to see by the next meeting on this, if anything, so that if we're concerned about sort of process here, like what is it when Frank comes to the table next time that we're looking for, or what is it that we need we're asking us to do between now and the next meeting, or it's nothing for right now and the budget process is the next step.
So. In my list, I feel like, as someone who works directly with this population. Obviously my involvement with it is pretty intimate. And so it's interesting, it was interesting to me when you said like, from like a broader view, it wasn't used as a spike, but it was perceived as a spike within the community when you just see like boom, 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 boom. And it feels like what people are hoping for is like something in the community structures that says, this feels wrong. Where can my information come from? So even if I understand that the health, like you're constrained by wanting to get accurate data, and that data is time because you have to send it out and then wait for it to come back. And in that time, stuff keeps happening. So even if it's just like, oh, the hospital says like, or the medical examiner has seen 2 or 3 deaths in a 2 to 3 day period or in a short span, where can we get information that goes out that says, hey, be safe, you know, here's a reminder as to where you can find Narcan training, Narcan strips or whatever else, something that just says like, if there's a concern, where can I go to find information that tells me how to be safer if we need it, even if it's not concrete information. So maybe that's just like a social media thing or something that like we can set, or you can send out something that says like, there's perception, like there's a concern for XYZ. I don't know how that happens, but I think that's what's kind of more of like, I felt like, you know, people see it on like Facebook or the Ithaca Voice or something else, but nothing from anywhere that you would want it to come from, like a health system or a health department or police department. So maybe just figuring out how to improve communications, like what you're already doing, to allow us to better communicate to the community when these things happen, to as just like a reminder of information to go out of like, if you're concerned, if this happens, here's where you go to get whatever. I think that's one of the things that is what I think would be helpful.
Yes.
Do we?
I thought it was.
I'm in the corner.
This way.
Do we as a board need a list of partners that we want to see that whole health is contacting? And then I guess before you can do that, one step before that is what information, as you were saying, do we really need to be able to convey the messages that we need for the community? So are we missing data? And what is that data that is missing? It's so and then you know, see that on the next meeting. And I mean, we need to start somewhere. So
Then I think it would be helpful. I know that I had a conversation with one of the public health workers at Rome, and they have a whole system whenever they see a surge in overdoses, including sending out texts to their community, letting them know that people are dying, there's a bad batch, keep your eyes open. And they also have like a whole process of how they're spending the opioid funds and how they're communicating with their community. So I think it would be great if maybe Frank or someone could reach out to Broome, just to, other counties are doing other things, and there's no reason for us to like reinvent the wheel, because some things are working, some things aren't. But I feel like we should be doing better work, you know, better than Broome.
Well, I'm just wondering, is more data necessary or is it not necessary? Is there enough data to say, okay, we know there's a problem.
Right.
You just need to improve the messaging to the public. That's all. Maybe that's the third bullet, is like to improve the messaging to the public. What are the areas that we need to improve upon that? Not necessarily gathering more information, because maybe there's enough information already present. Yeah, I'm just saying, I'm not, these are just maybe some
Good points. I don't
reasonable
disagree.
steps.
Yeah, I think to your point, I think more data isn't necessarily a good thing. You know, we might already have the data we need, and B, you know, maybe we all, you know, collectively can figure out things to do that don't require us to have extra data. Yeah, so I think figuring out, but I like the idea of, you know, what are other counties doing? Because it's not a Tompkins issue, right? It's a, you know, statewide, countrywide issue. So why not see what other counties are doing, other health departments are doing?
So, okay, I'm just conscious of time. So just to wrap this up for the meeting so we can move on, could Frank, would it be appropriate to request that or at least make sure it's a component of your part of your presentation to talk about just in a little more detail again, in terms of what progress have we made since this discussion into the next one.
Sure.
It sounds like one of the topic areas is around data and what we're doing around data. But I think the second to me is probably some reflection on some of the commentary that was made here about how the health department right now is positioning itself in the community relative to providing information.
Sure.
And giving you some space to think about that and maybe come back to us and say, okay, like we've thought about these different pieces and this is what we think is what is being expressed here is a desire for there to be a little bit more of a leadership role or presence from the health department than at least what we feel like we're experiencing.
Sure.
And you know, you'll have to define sort of what that means based on available resources, but
Sure.
but then also, you know, this is what we can do with what we have, but if we had X, Y, and Z to the budget point, then we could do these kinds of things. Is that with it is right?
Sure.
Understanding that we know you have other stuff on your plate too, so.
Yeah, no, this is much of what I do and much of what the leadership team, particularly at Green Street, is focused on right now. So it's, these are all good questions and I don't, I have no problem kind of pulling out and sharing. And if that's the way, if that's the perception of where we are, then we haven't been doing a good job communicating about what we've been doing anyway. So we need to do that as well. So yeah, that's
Okay.
perfectly fine. We'll make sure we put something together for y'all.
Yes, last word.
Yeah, just to identify the difference between communication with the greater community and sort of general awareness and what you mentioned before about targeting specific populations and, you know, where's the impact going to be the biggest and what's, you'd love to be able to do both super effectively, but given resources, you know, is it better to hit bars or food services or, you know, rather than everyone? I mean, there's got to be a balance there.
Okay, good discussion. I'm gonna move this on to Rachel and measles.
So yes, I wrote my report about the month of February and then we're almost at the end of March. And there's a lot of things that happened in the last couple of weeks. CDC issued new guidance on COVID. That was March 1st. And I just got a health alert from New York State DOH in my inbox dated today. So yes, confirmed measles case in Nassau County in a young unvaccinated child who has not traveled abroad. So I think CDC issued data that so far this year, you know, we're only in March and the total number of measles cases is more than it was the entire last year. So worldwide, there's increases and obviously we're an interconnected international travel world. A lot of these cases so far have been in international travelers, but I think they're noting now there's a young unvaccinated child who does not travel abroad. So lots of preparation coming from the state and from CDC on get ready because you'll probably have one. So if there's any questions, I'm happy to answer that, but.
So Rachel, what would happen if we have, let's just pick this.
Say that.
If the school, we would call Rachel. And we would know what to do.
It's a fair. Our kids not just getting the eclipse off, but.
Luckily, there's requirements for school, so the MMR is required for being in school.
You don't have any exemptions?
We have very few because the religious exemption went away, so now it's medical exemption, so.
Yes.
It's not like 2017 when we had no herd immunity in some schools, but now,
Yes.
now it's
Do we know what the percentage of immunization is in the school?
Yeah, yes, we do have, Deidre pulled a bunch of numbers for me recently on MMR coverage, but it's very good. I mean,
Over 95%.
for the school age population, yes. I mean, if you look at like 2-year-olds, you know, it's not as good, but because, you know, that kindergarten entry is an important data point there. Yeah.
I'm probably opening a can of worms, but I've heard rumors or a rumor or two that there's a doctor in town who's providing vaccination records that are not actually vaccinations. I don't know. I honestly do not know names or anything. And I'm just wondering how that is possible and if there's anything happening. Because apparently it's known that this person is doing that. And I just don't know. I'm seeing some heads nodding in the affirmative, so I'm not the only person maybe who's heard this.
And there's an awareness, I mean, I'll take it off of everyone's shoulders. There's an awareness of that. We've communicated with the State Department of Health. They have the authority to do something if they so chose. The challenge is they need someone who is impacted to be the complainant, is what we've been told. And generally speaking, the people impacted don't want to complain because they're getting something that they want.
Right.
So it becomes challenging. The reality is with doctors, you can hang your shingle and just start practicing medicine. There's minimal regulation unless you're part of a larger organization. So it's challenging. So when we are aware and we've had communications with DOH, we've had communications with the provider directly. It's tough. It's tough without actual proof and somebody willing to make a complaint.
And the state does monitor it, because I had that woman from Long Island who
Yes,
falsified
right.
11,000 records or something like that.
Yeah, if it's an ISIS, then you can.
Yeah.
Yeah.
You can crack down on that ISIS reporting, which was falsified. Any more questions about measles? I was just gonna do a brief staffing update too, because I forgot to put that in my report. I have successfully promoted a nurse internally to a senior nurse position, so Carol Silverman will start as senior nurse April 1st. I still have one opening for a senior nurse and also Carol's position that she vacated, so I'm hiring for two. I have some interviews scheduled in the next few weeks.
Okay, any other questions? Sam is not here, so we will have to take the report as it stands. Good. I don't have anything as exciting as measles, but and I'm pretty sure Frank summed up what I have been working on. It's not in the report, was gathering data from our current providers regarding retention and recruitment. So as soon as we have that data collected, we can make a decision moving forward on how we can try to keep our providers and possibly recruit more.
Can I ask about EI Hub?
Yeah.
It seems to be scaring everyone away.
Yeah, it does. Yes. So it is the New York State billing system. It's being transitioned from the previous system called DICE. Apparently that system has reached its capacity, which that doesn't make sense in my brain, right? They built the system. How is it full? So it's a new billing system that the providers in our department will be using. It has been in discussion for, I believe, approximately 4 years. I'm just hearing about it because I'm new, right? And the training for it is not necessarily streamlined at this point for each individual user. I think that's what's causing some of the frustration, and ultimately some providers are leaving the program because they don't want to learn it.
So if I were an EI provider, I would do my billing through this system, so they have to use it.
That's correct.
Right now, it's set to go live in June or July.
June.
Nice HO is advocating to get that pushed till at least October. Because there is a lot of angst about entering a new state system, which we all know will go smoothly on day one. And what that's gonna mean to our providers where we're already struggling to find them, because your point is. We're hearing the same things. Part of folks are saying, well, when that switch comes, that'll be my last day in EI, because I'm just not dealing with it, right? And so without support from the state, now it's added cost to them when they're already not seeing great cost of living increases even in their rate. So it's just one more issue that is exasperating our problem. having providers available.
Quick questions on that? All right, Liz.
I have nothing to add to my report.
Any questions for Liz?
I just want to shout out that we won the People's Choice Award for the chili cook-off
Oh,
in my daughter's second, third grade class. We did pass our inspection when the health inspector came. I will say that the Statler Hotel was one that was in violation. We were not, so, and I did not use any influence to say that I was on the board of health. But no, but in all seriousness, I thought it was a great event. We had a ton of people show up.
Great.
So it was really nice.
Right, let's go ahead and move to enforcement actions. The first one is for pizza and bones. This was the cold holding one, right? Yeah, cold holding. If we, okay. So I'll take it first from Melissa to accept as written, and then a second from Ed. All right, let's go ahead and open for discussion. Liz, is there anything in addition to what's already in here that needs to be discussed? Or, I mean, okay, any questions for environmental health? Yes.
Actually, we do need to change the date, so
Right.
they should be May 15th for the penalty due date. We would need a motion to modify.
If to change dates.
You can just, if it's friendly to the mover and seconder, then you can just make that change.
Okay. And it's just on this letter, right?
The
The
resolution.
resolution.
From April 15th to May.
To May
15th.
15th. Yes. All right, anything else on this? Okay, so all in favor of approving almost as written with the friendly amendment of the change to the date? We are unanimous. Okay. So second one up is the is for Argos in. Motion to approve this written. First from
You
Sue.
need to have her make a motion.
Yeah. For the date changed, okay. Approved with as almost as written with the date change on the resolution to May, from April to May 15th. We have a first from Sue, a second from Dr. DeLima. Okay, Liz, any other discussion on this one that's necessary from your perspective?
No, I mean, a lot of this seems to be kind of staff control or training and stuff, and so they have submitted some training protocol that we're in the process of reviewing.
Any other questions? All in favor with the amended, as written, but with the amended date of May 15th? And that's unanimous. Okay. Anything else for the good of the group before we go ahead and adjourn? Covered our entire agenda. Have a wonderful March. March, and we'll see everybody in April.